Welcome to All Access, where we meet at the intersection of healthcare and generic and biosimilar medications. Brought to you by the Association for Accessible Medicines, representing the generics and biosimilars industry. This is a special edition of our Allies, Thinkers, and Scribes and our podcast. So first time ever, actually, that we've done it this way. So we appreciate it, and we're really excited about having Bob with us for this chat. It's good to see so many people. We appreciate everybody coming out for this morning. This is really a live studio audience, and you're all in your own personal studios in your office or your home office. We've got a number of our members here, board members that I've seen, and of course, a number of our colleagues from AAM. We'll have opportunity for people to ask questions of Bob, and I'm very much looking forward to that and to engaging with Bob. All right, so let's get right into it. Every September, we take time to reflect on and commemorate the signing of the Hatch-Waxman amendments. This was the historic legislation that laid the foundation for our present-day generic drug industry. And it was 37 years ago, September 24, 1984, that President Ronald Reagan signed into law this skillfully crafted legislation. A signing ceremony in the White House Rose Garden, surrounded by groups of legislators, including the bill's two namesake authors, Orrin Hatch of Utah and Democrat Henry Waxman of California. President Reagan at that time, at that ceremony, called the new law a win for everyone. It gave regulatory relief for generic companies, increased research incentives for brand companies, and best of all, the president said, gave savings to the American people while assuring they would continue to get the best medicine pharmaceutical science can provide. And as we know, that's exactly the remarkable legacy of Hatch-Waxman up to today. Incentives in the law have spurred unprecedented research and development of new medicines, and market competition from generics has enabled patients, consumers, and the health system to save billions of dollars each year. And our annual access and savings report just came out recently, and in the 2020 savings associated with generics coming to market, $338 billion. That's 1 year of savings, a remarkable number that has been going up every year. To help us celebrate the anniversary of Hatch-Waxman, ATS, that's Allies, Thinkers, and Scribes, and All Access, the podcast welcomes industry veteran and generics expert Robert Pollock. Bob worked at FDA in the earliest days of Hatch-Waxman and was among the very first new employees of the new division of generic drugs. So a real pioneer on the regulatory side of our industry. And he joined in 1984 after Hatch-Waxman was passed into law. And this later became the OGD, the Office of Generic Drugs, and it was organized in the summer of 1989. So today we're going to hear some of those stories, some of the stories Bob has from those very early days and the beginnings of our industry, frankly, and his firsthand knowledge of how the industry that we are all part of was formed and how it has evolved into what it is today. So with that, Bob, welcome to our very special edition of ATS and All Access. It's a pleasure to have you with us.
Thanks, Dan. I appreciate the opportunity to participate in the program.
So tell us a little bit about yourself. You live in Southern California with your wife, but where'd you grow up, and what are some of your hobbies and interests?
Yeah, I was actually born in Trenton, New Jersey, the home of the best pizza in the country. And I lived there until after elementary school, and we moved across the Delaware River into Yardley, PA. Went on to junior high school, then Pennsbury High School, go Falcons. In terms of interest, I really love all sports, but I concentrated a lot on soccer, which is really my passion to today. I follow a lot of the English football leagues and La Liga and things of that nature. But I also played. I played at the time when most people didn't even know what soccer was. I played in junior high school and high school, and a couple years in college because of pharmacy kind of conflicted with playing all 4 years. And I also played on a semi-pro team in San Diego for 4 years when I was stationed out here. My wife and I love the beach and hiking. I love boogie boarding and spending time with my family. I have a son and a daughter, 2 grandkids, and my son lives in Kentucky. My daughter lives 3 miles down the road from us, and she has a grandpuppy for us.
Yeah, so you got the best of it all right there in Southern California with the weather and the waves for your boogie boarding.
Absolutely. We 10-minute walk to the beach.
And we can ship you a pizza from Trenton anytime you
Yeah, Di Lorenzo's. I used to live right around the corner from the original Di Lorenzo's.
You studied pharmacy, I'm assuming, in college. Where'd you go?
Well, I was going to go to Bucknell in chemical engineering. I wanted to play soccer there. But about 3 months before school started, we got a call from the soccer coach at the University of Rhode Island. He asked my best friend and I to come up for a weekend visit. And once we got to Kingston, Rhode Island, after a brief chat with the coach, he turned us over to a fraternity for most of the weekend. Two 17-year-old boys turned over to a fraternity. What could possibly go wrong? So we experienced football games and college parties, and that basically sealed the deal. My friend and I decided right then and there that URI would be our home for the next few years. I actually started my college career at URI in chemical engineering. But what got me into pharmacy was one word: calculus. I found out that after first 2 semesters at school, calculus and I did not mix. I liked chemistry, so I went to my counselor, asked him what had chemistry, but no more math requirements. And he said pharmacy. So that was great. I went into the program. But one of the best things that happened to me at URI was I met my wife. We got married right after my 4th year, and we just celebrated our 50th wedding anniversary in June. After pharmacy school, I stayed at URI for another 2 years, pursuing a master's in pharmacy administration, and that was pretty much my college career.
Well, we all in the pharmacy sector in our industry, we all have calculus to thank for Bob Pollock joining the ranks. And there might have been a couple of recruitment violations in that, but maybe not in the early 70s, I'm guessing.
Yeah, they didn't know, NCAA didn't know what recruitment violations were in the 70s.
Got it.
Actually, it was in the 60s, 67.
So after URI, graduate school, then into the U.S. Public Health Service at HHS.
I started my career in the New Orleans Public Health Service Hospital as a staff pharmacist. I spent 2 years there and then was transferred to San Diego 10 days after my son was born in New Orleans. I spent 5 glorious years in San Diego as the deputy chief of the pharmacy department. And then I was transferred back to the Maryland, DC area in 1981 into the Bureau of Medical Services headquarters. And Bureau of Medical Services were the ones that ran the 8 general medical hospitals and 27 outpatient clinics of the Public Health Service. But apparently I was going there to get some experience and maybe go back as a clinic director or maybe a hospital administrator. But I think President Reagan had other plans for me, because shortly after I moved to Maryland, he closed the hospitals and clinics. So I went from focusing on running that system to now shuttering it down. And it was some pretty interesting times there. I was in charge of disposing of all the pharmaceuticals from all the companies, from all the hospitals and clinics. And that was quite a task. I had a couple other little assignments along the way. I spent about 2 months doing a special pharmacy consulting gig with the Bureau of Prisons up in the Northeast Corridor. And I can tell you, when you walk into the Lewisburg level 4 prison and they shut the door behind you, you wonder if you're ever going to get out. I also did a stint in Fort Chaffee, Arkansas with the Cuban Haitian refugee program. I was sent there to start the pharmacy program. When I got there were 3 refugees. And when I left a month later, there were 25,000. So I just set up the pharmacy program instead. Then I went into the Health Resources and Services Administration, running a contract healthcare program to take care of the Public Health Service, National Oceanic and Atmospheric Administration, and the Coast Guard, active duty and their dependents and retirees. And that was taking care of the people that used to be served by the PHS hospitals and clinics. But I was doing mostly financial stuff back then. In 1984, I was kind of getting tired of it. And I really wanted to change. And I was riding up the elevator in the Park Lawn building, and I was on the elevator with Kent Johnson, who is a pharmacy director from the hospitals and clinics. And I knew he transferred to FDA after the closure, but I wasn't sure what program he was really working in. I knew he was working under a new piece of legislation, and I didn't know what the legislation's name was, but I knew it was to expand generic drug approvals. So I wanted to use my pharmacy background. So I asked him right there on the elevator, "Hey, Kent, do you need any good pharmacists?" And he goes, "Yeah, we do. Do you know any?" And that was how I started. in FDA. I interviewed one week, and the next week I was hired. That was in November of 84, but I couldn't transfer to FDA until February of 85 because of the commission corps getting all the your orders and things done. So while I was in the generics program, I held various positions of increasing responsibility, originally in the Division of Generic Drugs, and over the years, which transferred organizationally to the Office of Generic Drugs. I started as a consumer safety officer, bottom rung, became a deputy chief of the review support branch, then chief of the review support branch, chief of the program support branch, director of the Division of Labeling and Program Support, and my last position was as acting deputy director of the Office of Generic Drugs.
After government, you joined Lockman Consultants, and you're still associated with Lockman, but tell the folks who may not be familiar with Lockman a little bit about the company and what you do for them.
Sure. I love my work at FDA, but it was really time for a change. And I was trying to decide how to best leverage my FDA experience. And I was fortunate to have the opportunity to be picked up by Lockman Consultants. As the name implies, it's obviously a consulting company. And I found consulting was really the best fit for me, as it was similar to a lot of the stuff I was actually doing at FDA. Answering questions about applications, about the statute, about the regulations. How do you do this? How do you do that? And that to me was a lot of fun. And through my 26 years at Lockman, I moved from senior consultant to vice president, senior vice president, retired in 2012 as executive vice president of the company in the regulatory practice. And as you mentioned, I continue to serve as senior advisor and outside director to the board. I also I manage and write about 95% of the Lockman blog. Lockman serves all areas of FDA-related activities in the pharmaceutical, biologics, diagnostic, device, and allied health industries. And we offer a complete suite of services in the field of compliance, which is actually our largest practice area, in science and technology, which deals with analytical, manufacturing issues, and in regulatory. Because of confidentiality, I can't mention any of our specific clients, Dan, but we serve over 250 clients in the industry.
So it's not a new issue, but what are your thoughts on where we are on this issue of prescription drug pricing?
I really feel that the generics program gets a bad rap here. There are some drugs that are priced higher than others, and there's been some issues in the industry lately that they've had to deal with. But the real issue, I think, comes with the branded name drug products. Brand name drug products, I mean, some of the prices, I've seen articles recently where they talked about the Hep C drugs. When the first innovator came on, it was like 60 grand a year. And then when the second innovator came on, the price dropped dramatically. Well, the same thing happens obviously with generic drug products, but a lot of the high priced drugs are really the innovator drug products. I don't know why everybody keeps picking on generics, because the price margin is the profit margin so small. Everybody in the distribution chain takes a piece of the action, and some of the smaller firms get driven out of the market. So I really think that generics get a bad rap in that regard.
Our job is to tell the story of generics and the value that they bring to patients every day. We say here at AAM, if high drug prices are the problem, then you're looking the solution straight in the face. And that's us, the generic industry. We're very proud of what we do to bring quality medicines to patients at affordable prices. So we talked about your early days at OGD. Let's go back to that time. Hatch-Waxman has just been passed into law. FDA had created the regulatory pathway for approving generic versions of off-patent brand drugs. But why was Hatch-Waxman necessary at that time, in your opinion, Bob?
Let's take a look at the broader picture. There's two pillars of importance in relationship to drug product approval, and that's safety and efficacy.
Right.
In 1938, the Federal Food and Drug Cosmetic Act instituted the requirement for approval of drugs by safety. And the precipitating factor of that was a tragedy, the sulfanilamide tragedy. And we can talk about that more in Q&A if anybody has anything they want to ask about that. But the interesting thing was, even though you only got approved for safety, there wasn't an affirmative approval requirement there. So if you submitted an application and FDA didn't act within 90 days, your application was deemed approved. So that really created the first pillar, the efficacy pillar. And in 1962, Kefauver-Harris amendments, coming on the heels of another tragedy, the thalidomide tragedy, required drugs approved after 62 to be both safe and effective. So now we have a 22-year period between, or whatever the period is, between 38 and 62, where drugs were approved. FDA developed a way to evaluate those drugs that were approved only for safety through the DESI program, Drug Efficacy Study Implementation Program. So now those drugs become approved for safety and efficacy if they met the requirements of the DESI program. And that's only for drugs between 38 and 62. Products approved for both safety and efficacy after 62, where the real opportunities for competition were rooted, and there really wasn't a pathway to submit generics. In the DESI program, when they issued the DESI review, found a drug product efficacious, there were outlines in the DESI notice that allowed applicants to submit abbreviated applications for those drugs. And just recently, we found out that those products were actually really approved under Section 505C and not under Section 505J. And they brought us a new animal, the panda. But anyway, getting back to this, many of these off-patent drugs were required to do full new NDAs with associated adequate and well-controlled clinical investigations, or a paper NDA, kind of akin to the 505B2 application we have today, but obviously a little bit different. And that paper NDA relied only on an analysis of published literature to establish both safety and efficacy. But unfortunately, since the amount of published literature on most of these products was very scant, firms were either closed out of the market or were left to repeat expensive, duplicative clinical investigations, duplicating the same studies that were performed by the brand name product. Now that has to ring true when everybody thinks about Hatch-Waxman. Mm-hmm. The Drug Price Competition and Patent Term Restoration Act, or Hatch-Waxman, it used to be Waxman-Hatch, but then when the Republicans took over, they changed it, of 84, confirmed for the first time the government's view that the repeat of the expensive duplicative clinical studies to prove what was already known was not necessary. And that was a biggie. With the rise in medical costs to consumers, the government through its Medicare, Medicaid programs, other government programs like the military and the VA, the costs were just outrageous. Hatch-Waxman gave a new regulatory pathway that offered a way for these previously shielded post-62 drug products to be brought to market in a much easier and cheaper manner while assuring their quality. As we all know, the Act provided that if your proposed product was the same as the reference listed drug upon which you relied for safety and efficacy, you could demonstrate bioequivalence of the product, and now you had an abbreviated pathway rather than the clinical efficacy studies and the toxicology to bring your product to market. This was the drug price competition part of the Act. However, it also provided a balance between generics' reliance on the safety and efficacy of the innovator products by protecting innovation in the form of providing patent extensions for innovators, requiring patent certifications of generic applicants, and for various periods of market exclusivity for the innovators. This was the Patent Term Restoration Act. Both parties got something. Everybody had to give up something, but it worked. Interesting, here we are on the 37th anniversary of Hatch-Waxman, and we're still having the same dialogue on pharmaceutical cost containment, even though trillions of dollars have been saved by the use of generic drugs since the passage of the Act.
Yes, back to the future, right?
Yeah.
Okay, so Hatch-Waxman signed. The Office of Generic Drug very quickly starts receiving ANDAs and paper ANDAs, as you said, and so I'm just envisioning stacks and stacks of applications flying in for approval purposes. I think I read 1,000 generic applications in the first year after Hatch-Waxman was approved and signed into law. How was the agency handling all that? Were you prepared for this gold rush, if you will?
Yeah, well, it was a gold rush, but I think we have to characterize it at that time as an avalanche of applications. The Act was passed on September 24th, 1984. Implementation was 60 days later. Now, we'll talk a little bit about this later on, but on November 24th, trucks were parked at the park bond, at the loading docks, bringing off applications, as were presidents, VPs, and in some cases, even CEOs of the company, regulatory affairs people, carrying in applications in boxes to our document room. In the first 2 months of the program, over 400 applications only for post-62 products. Now, we still had applications coming in for the pre-62 products and also antibiotic applications, but 400. And the yearly figures, I went back to some very old presentations I had done. In fiscal 82 through 84, the program received an average of 425 applications a year. And that included the antibiotics and the pre-62s. So we got 1 year's worth of work, basically in the first 2 months of the implementation of Hatch-Waxman. And yes, Dan, your estimate is pretty much right on the mark. In 1985, the program received 1,069 new ANDAs, of which 643 were for post-62 applications. The following year, we received 1,062, 814 of which were for post-62 applications. And in 87, we received just under 1,000 at 988, with 717 being post-62 applications. So as you can see, as time went on and people had to load the pipeline, they started loading more with the post-62 drug products. And as I mentioned before, these did not include antibiotic applications, which were submitted under Section 507 of the Act back then. The shelves were full of applications, and our offices were piled high with applications, so high that standing at the door of some of the offices, you couldn't see if a person was sitting at the desk. We had 2 people or 3 people in a single room. Our document room was filling faster than expected. The pipeline was not only full, it was overflowing. And it was organized confusion during the early days. Some people call it the wild, wild west. Yeah. I like the term organized confusion. Okay. Staff wasn't yet fully trained, but was expected to move the freight. And we did it. Within 6 months, all of the initial bolus of applications were acknowledged. New staff was coming on board, and by July of 85, staff training had been pretty much completed as predicted. And the number of ANDA submissions seemed to level off. Well, that prediction didn't hold true, because just 2 months later, in August of 85, submissions began to spike again. Another assumption that proved less than accurate was that firms would concentrate only on applications for post-62 drugs to expand their product lines. However, firms were really beginning to carve their niches in this new generic market, and were searching for something new. And while ANDA products were to be the same as the reference listed drug, they were looking at unique opportunities that were afforded to them under the ANDA suitability petition, or Section 505J2C of the Act. And that gave them the opportunity to change certain aspects of a reference listed drug product, namely the same things that had to be the same. You could change a dosage form, strength, substitution of one ingredient for another of the same therapeutic class if there was a known equipotent dose relationship between the two entities, or a new route of administration. Congress gave the ability to change a new route of administration, but since the passage of the Act, not a single petition has been approved for a change in route of administration. And that's primarily because when you change a route of administration, there's almost always safety issues associated with that.
You know, certainly growing pains from those early days. There was no user fee in place, so there was no GDUFA to help finance this, or to to bring in additional colleagues to help you get through that. Was OGD staffed appropriately? Could you handle it in that regard, or were you dramatically understaffed for what was coming at you?
And understaffed is an understatement. The issue was we really had only 60 people during the early years of Hatch-Waxman. When I left the agency in 95, we had 155. Now there's about 1,000 staff members between the Office of Generic Drugs and the Office of Program Quality. But despite the challenge we faced during those years, the approvals began to flow. With the workload, we were coming in at, especially the Commission Corps officers, we're coming in at 6 in the morning and leaving at 5 at night just to get things moving. But the approvals began to flow. In 85, we approved 389. And then the following year, as things began to ramp up, we jumped up to 616. And in 87, fiscal 87, it was 660 approvals. And this did not include antibiotic approvals, which accounted for between 100 and 200 additional applications. You have to remember that one of those chemistry branches was devoted only to antibiotic approvals. So if you take that away from the 60 people that were there, and that's like 5 or 6 people, we were doing a lot of work that 1,000 people do today. So, and I mean, granted, the documentation practices are a lot different today. There's a lot more requirements, but it was a challenging. And somehow we exceeded with limited staff, tremendous workload, and constant pressure. But we delivered low-cost, high-quality generics to the American public in a timely manner. I'm sure I don't have to tell you about the program's success.
What were some of the challenges that you were facing at that time, with massive influx of applications and people, frankly, testing the limits of what the agency was responsible for handling? That's
an interesting question, and it kind of leads me back to the late 80s. This constant influx, I mean, during the early days of Hatch-Waxman, industry people unfetteredly walked the halls of the Park Lawn building. They would pop into offices, into the chemist's office, the regulatory support staff office, into Dr. Seif's office, in the chemistry supervisor's office. And remember, I said, you know, there was a lot of applications hanging around. So if somebody walks in your office, you can't just move all the applications. So I think there was a little bit of competitive intelligence going on there. But there was also a lot of pressure. I mean, we had pressure from the industry, from Congress. We had pressure from the public. The public wanted cheaper drugs. And over the course of time, some unscrupulous industry folks tried to find weak spots in the personnel.
Thank you, Bob, and everybody on this call today appreciates those words, and we thank you for your work in those early days at the agency. So we've got some questions coming in. I'd love to get to those. First one up, before GDUFA, you mentioned the backlog of thousands of ANDAs coming in. Generic companies were opposed. All drug companies, I think, initially were not too keen on the user fees, but now we have GDUFA. It's in place. It works. As you've noted in some of your recent blogs, the fees are going up. The GDUFA fees are going up, but the volume of ANDAs at the agency is not necessarily going up. In some cases, it's going down. So, does this add up for you, or is the industry getting shortchanged at the FDA?
That's a good question. It's hard to tell because there's a lot more going on at FDA than used to go on. I mean, when you think of all the additional things they do, but the number one things for industry is approvals. And if you're not driving approvals out, then you're really you are to some extent getting shortchanged. The first cycle approvals, if they don't improve, I don't think the program's ever really going to get over the I don't know if I can't remember, it was mean or median at 34 months to approval. The industry is going to be up in arms. Something has to be done to improve communications during the review of applications to avoid the constant cycling of complete response letters, IRs, and discipline review letters. Telephone works pretty good for solving some of these things. And I know they want to document everything, and they don't want people to jump the line, and they don't want people to get an advantage over each other. But the first cycle approvals, you'll see it month to month. I report it in the blog. It goes anywhere from 8% to 20%. 94% of NDAs are approved in the first cycle. Now, granted, they have a lot more reviewers and things like that, but that to me is a thing that gives me angst.
Yeah, I think a lot more complex products are being submitted now on the generic side too. But the next round of GDUFA is designed to take care of some of that. So this question is related to the last one. But if new drug approvals and new molecular entities are being approved within 10 months of filing, but 34 months, as you just noted, is the average for generics. How should we think about that? Why is there such a gap between the the 10-month and the 34.
Well, there's a couple things that contribute to that, Dan, in my opinion. One is obviously the constant recycling, but you got to remember that cedar, on the quality side of the house, OPQ says they speak with one voice. They don't, in my opinion, because the chemists are trained differently. People that pick up your application are trained differently. You have analytical chemists that concentrate on analytical issues, organic chemists that concentrate on other issues. So you see different reviews from these chemists, even though things are supposed to be pretty standardized. And part of the problem with the recycling of applications is that, and I was talking to somebody at FDA about this the other day, that review under GDUFA is supposed to be complete. But you will see, and by show of hands, the industry people that are out there, even though I can't see you, raise your hands. You will see in cycle 2, cycle 3, and cycle 4 sometimes new issues being raised. You're not supposed to go back and re-review an application. And I don't know why this happens. Part of it is because, in my opinion, when I was there, what I saw was the supervisors didn't have enough time to really go back and look at the underlying data that supported the deficiencies that were coming out in the application. So you had to deal with that on a continuing basis. But again, it all relates to first cycle approvals and really everybody doing their job so that we can get these things done in a reasonable period of time. 34 months to me is still unacceptable.
Right. What do you think of the supply chain issues that our industry faces, and from the political side, where there's a large chorus of voices saying we need to bring more manufacturing and production back here to the United States?
Yeah, it's always kind of puzzled me that you're really dealing with two different things. You're dealing with bringing the manufacture of APIs back domestically when you're dealing with OASH issues and the restrictions on use of solvents and things of that nature in this country. It kind of belies the fact that you think it's going to happen. There's a lot of stuff that we can't do unless other agencies, or other government agencies, change what the allowable things are for these products. It's hard. There was an API manufacturer up in Rhode Island that had a huge explosion quite a few years ago, and all of the drug that caused that is manufactured overseas now. Nobody else manufactures it in the United States. So those kinds of things have kind of occurred. And then you have the disparity in labor costs that are just killing us. If a company buys something for $1,000 and it costs them $2,000 to make, you can't make it up on volume. Those kinds of things occur. And the supply chain, even if you try to order anything online, you get a notice back, well, sorry, your order's been delayed. And the same things happen in the pharmaceutical industry. Shortages on vials, shortages on glass ampules and vials. Simple things that you would think are crazy. But when I talk to people in the generic industry, the companies in the US, they're dying because they can't get the active ingredient, or the campaign in Europe went from 3 or 4 times a year to once a year. So unless the supply chain straightens out, and there's a recognition that it might take a long time, and there's a lot of things you have to do to fix the supply chain, not just say bring the products back. You have to deal with multiple government agencies to be able to allow that to occur in the U.S.
Well, and so we're still in the midst of a pandemic, but I think it's fair to say that our industry was very resilient during the pandemic, and that while there were shortages of PPE, there were shortages of masks and gowns and lots of different medical components, there were not significant shortages of essential medicines, and that's something that we work on every day here at AAM. And you mentioned glass vials. We know also. Due to the Defense Production Act, there were significant shortages of glass vials. So many of our manufacturers, really struggled to get their hands on those to manufacture their medicines. But all in all, held up well.
Yeah, very well.
But it did not break. But it's an issue that we work on, and we talk to members on the Hill and in the administration every day on this topic. So we're about at time, Bob, and this has been a lot of fun. We really appreciate your joining us today. Is there anything else you'd like to say before we sign off?
No, I just, everybody out there, keep working hard. We have to keep this program going because it's really saving a lot of people and it's saving a lot of lives.
But I want to thank everybody for joining us today on this very special edition of Allies, Thinkers, and Scribes, as well as the AAM All Access podcast on the 37th anniversary of the signing of the Hatch-Waxman Law. Now, please share our appreciation for today with all your colleagues, and make sure that you log on to Lockman Consultants and make sure you're receiving Bob's blogs. You'll be smarter for it. So thank you to Bob, and thank you to all of our audience here today. And we'll see you next time.